Good morning. Welcome to our grand rounds today, and we're very fortunate to have a distinguished visiting professor here today to give us grand rounds and in honor of the John P. Brantner Memorial Lectureship. And as I myself am just, one of the wonderful things about being a chair, particularly a new chair, is that you get to come into a department and learn about these real sort of little hidden gems of activities that have been going on in the department that you never knew about. And you walk in the morning and you find out about this sort of wonderful lectureship. And so I'm going to tell you a little bit about a few minutes, just telling you a little bit about the lectureship, and then introduce our speaker. Let's see here. So this lectureship is in honor of Dr. Brantner, who was born in 1921 in Illinois and received his BA and PhD in psychology from the University of Minnesota. He was appointed to our department as an instructor in 1954 and then made his way up through the ranks, and he achieved the rank of professor in 1969. He later also held an adjunct appointment as a member of the graduate faculty in the Department of Psychology, and he was also a lecturer in the medical school. Dr. Brantner was an extremely popular professor, and he received the medical school's Outstanding Teaching Award in 1969 and 1977. He was a highly sought-after community speaker as well, and despite the fact that he had a distaste for flying, apparently, he willingly traveled throughout the country, as well as Minnesota, to speak on various mental health topics. And his work focused on those who had terminal illness, who were poor, who were elderly. Dr. Brantner was found dead in his South Minneapolis home on February 22nd of 1987 of an apparent suicide. And I'm not sure I understand this slide. We will just, it was an interesting slide. Oh, these are the topics that the past lectureships have focused on. Wonderful, wonderful. Okay. Well, you can, and again, you can see some of the emphasis. So this lectureship was set up with a couple of how should I say, areas of focus or emphasis. And the first was that this lectureship would honor a scholar and professor who held a psychology degree, who was a PhD psychologist. And the second was that this lectureship would in some ways support further knowledge and understanding on areas related to serious aspects of mental health issues, including suicide, and understanding, to develop a better understanding of what are some of the factors that can lead to the kinds of high risk and behaviors that might end up in suicide. And perhaps just a comment, as we all know, it sometimes is hard, in terms of interfacing with the external community or the press and so forth, as we know from other things that have happened in our department, but that suicide is part of the risk, in a sense, the mortality risk that is associated with serious mental health disorders. And if we are going to push the envelope forward in terms of knowledge about the factors that might lead someone to suicidal behavior, we have to just be willing to sort of march forward, embracing the risk of working with people who have these kinds of serious risks in their behavior. And so perhaps it is extremely fitting that in honor of Dr. Brantner and in honor of this emphasis where we are going to march forward bravely, seeking knowledge, including new knowledge in people with serious illnesses, that we have the great fortune of having Dr. Carla Sharp, who will be talking to us about borderline personality disorder. Dr. Sharp is professor and director of clinical training at the University of Houston. She received her PhD from Cambridge University in the United Kingdom. Her research, and I can attest to this having had a wonderful conversation with her just a short while ago, is very translational. And she focuses on social cognitive mechanisms that are associated with mental health problems in children and adolescents, with a specific interest in how emerging personality disorders might manifest themselves in youth. She's published over 150 peer-reviewed articles, numerous chapters and books, including the Handbook of Borderline Personality Disorder in Children and Adolescents, and her research has been supported by the NIMH, the NICHD, and foundation funding. And again, I just want to say on a personal note, it was very stimulating, a brief conversation, but very stimulating conversation with Dr. Sharp. Here's someone who's able in her thinking to start to form the connection or the dialogue between what we're beginning to understand in terms of the social neuroscience of human interaction and human attachment, the nervous system responses, the embodied responses, but is also able to think about how you make the connections with this new science and decades of very thoughtful and fruitful observation by, for example, object relations theorists who have thought a lot about attachment, representations of self and representations of other, and that capacity to move back and forth between those two domains of almost of inquiry that have different languages and different sort of worldviews is very rare indeed. So I personally am very much looking forward to your lecture in honor of Dr. Brantner, and welcome and thank you for coming to Minnesota.
Thank you so much, Dr. Vinogradov, for that lovely introduction. I too found our very brief conversation very stimulating, and I'm so excited for your department that you are now here. I want to also thank Mike for organizing everything, getting me here, and for your whole administrative team that helped with the preparation and getting me here. I am going to talk today about the early detection and intervention in borderline personality disorder. So I'm not going to talk a whole lot about social cognition today, but I'm really passionate about that line of research, and I've already, in my meeting this morning with the eating disorder group, talked a little bit about mentalization-based approaches. So if there is time in my visits today with anybody, please do ask me about that as well. I want to start off with, let me see how I can move forward. Okay. Oops. It's not self-evident. It's this, if you click this side. This side. I see the arrow because of, yeah. Thank you. Ah. Let me see. It's the button which is unmarked on the. I wonder.
It's down here. It needs to be fixed.
Ah, it's not on the right one.
This should work now. Or not.
Is this guy not working?
It could be.
You don't like to walk anywhere.
Yeah, I can stand where I am and.
Use the spacebar then.
Okay.
Can I use spacebar? Okay.
This should work now.
Yay. Thank you. All right. There we go. So where I would like to start is a study by Drew Weston that was conducted in 2003. And what he did was he asked clinicians working with adolescents to randomly select one of their adolescent patients. And I'll invite you to do a kind of thought experiment with me this morning. Just think about the adolescents that you've seen in this last week. He included in that study about 296 adolescent patients, and the clinicians were highly experienced, so they had about 13 years average experience. Post-training, 34% of them were from a psychodynamic orientation, 11% from CBT, and then 42% were eclectic. Most of them worked in multiple settings, and they knew their patients well for about more than 20 sessions. He asked them to do two things. He gave them a clinician assessment tool that had a lot of questions about personality disorder in them. And then he also just asked the clinician to diagnose the adolescent patient as they would in their regular practice. And what he found was that only 28% of the adolescents received a PD diagnosis, most commonly borderline personality disorder, although 75% of patients actually met criteria based on the clinician's report when they used the more standardized assessment tool for PD. So since this first study of Weston in 2003, there's really been an explosion of research in adolescent borderline personality disorder. And so there you can see really the increase since 2003 going up like that. And in addition, the psychiatric nomenclature does provide for the diagnosis of BPD in adolescents. Both the DSM-5 and the ICD-10 provide for the diagnosis, and I'll talk more about that a bit later. And the diagnosis of borderline personality disorder is included in the national treatment guidelines for both the UK NICE as well as the Australian National Health and Medical Research Council. So, given this explosion in research in BPD in adolescents and the fact that it's legitimized in the psychiatric nomenclature, we would expect that there is much more openness and acceptance of the borderline diagnosis in adolescents. However, if we look at a study that was conducted 3 years ago by Annelies Lawrenson and her group, it was conducted in 596 psychologists in the Netherlands, 75% female, mean age 40, again experienced clinicians, 27% in primary care, 58% in secondary care, 14% in psychiatric hospitals. 57% agreed that PDs can be diagnosed in adolescents. However, only 8.7% reported that they diagnosed PDs, and only 6.5% offered specialized treatment. And you can see there 25% offered MBT, 17% ERT, emotion regulation therapy, 12% schema-focused therapy, and then 12% DBT. Same thing, or the same message was reported in Griffiths et al. For 2011. What Griffiths did was, during an annual meeting of child psychiatrists, he asked 52 child and adolescent psychiatrists about the PD diagnosis in adolescents, and 82% accepted the overall validity of BPD for adult populations versus 37% for adolescents. 2% accepted validity for children under 12. 23% used the diagnosis in regular clinical practice. Of those, only 60% fed back the diagnosis to the adolescent. So that would mean a very small proportion, actually, of that 23, then, of the full proportion gets talked about with BPD. The qualitative feedback that clinicians gave was that the diagnosis can help families and young people understand their experiences and difficulties. It may also help young people access appropriate interventions like DBT. The label may have stigmatizing, marginalizing, and objectifying effects on young people. Making the diagnosis can lead to a worsening of difficulties. The diagnosis leads to therapeutic pessimism and a belief that change is impossible. The diagnosis is conceptually problematic as it omits crucial developmental factors and makes assumptions about the enduring nature of certain personality variables, which is considered developmentally naive in adolescent populations. So he concluded that the diagnosis is conceptually problematic, empirically insufficiently supported, and lacking clinical utility. And many of you in the audience may share some of these misgivings about the BPD diagnosis. And what I'm going to try and do in this talk is to try and challenge some of those ideas that you have. Andrew Channon published a paper in 2008. He's one of the leaders in the field for BPD in adolescents, and talked about BPD as the diagnosis that dare not speak its name. My daughter would remind me that that's Voldemort in Harry Potter. But I'm going to try my best today to give you a little glimpse into the research base in support of the borderline diagnosis, or at the very least thinking about BPD in terms of symptoms when one assesses and treats adolescents in regular routine practice. So the learning objectives are then to understand the barriers or myths regarding early detection and intervention of BPD in adolescents, apply recent scientific evidence to facilitate early detection, especially assessment. The largest portion of my talk will focus on assessment and intervention of BPD in adolescents, and describe the aims and goals identified by the Global Alliance for Prevention and Early Intervention of BPD. It's a new initiative which I'll finish the talk with today. All right, so what are these beliefs that have emerged from this literature that we now know are posing barriers to the early identification and intervention of personality disorder in general, but BPD in specific in adolescents? So number one, the psychiatric nomenclature does not allow the diagnosis. 2, certain features of BPD are normative and not particularly symptomatic of personality disturbance. 3, the symptoms of BPD are better explained by traditional axis 1 disorders. 4, adolescent personalities are still developing and therefore too unstable to warrant a diagnosis. 5, because PD is long-lasting, treatment-resistant, and unpopular to treat, it would be stigmatizing to label an adolescent with a PD. So I'll start off with that first one, and I'll concentrate most of the talk on this one. So Just as a reminder, 25% of clinicians believe that psychiatric nomenclature does not allow for PD diagnosis, and I won't make you put up your hand to disclose whether you've seen this in the DSM or not. But it is true that since DSM-3, actually, the diagnosis of PD has been allowed in the DSM. The DSM-5, of course, has two sections now. Section 2 is the diagnostic criteria and codes that really mirrors previous versions of the DSM in terms of personality disorder. And Section 3 covers emerging measures and models and presents an alternative model, a more dimensional approach to the assessment and diagnosis of personality disorder. And for another lecture, I can come back and talk to you about that. It's really exciting. You've got Bob Kruger across the river, who's been on the work group, who developed this this approach to PD assessment, and many of us think that that's the future for PD assessment. But here's what is in Section 2. The three clusters that many of you will be familiar with, cluster A, B, and C, and then borderline personality disorder falling in this dramatic, emotional, and erratic cluster of cluster B. You guys are mostly familiar with the 9 criteria. I'll go through them very briefly. Abandonment fears, unstable interpersonal relationships, identity disturbance, impulsivity, suicidal behavior, affective instability, chronic feelings of emptiness, intense anger, and transient stress-related paranoid ideation or dissociative symptoms. So you can really, if you kind of divide them up, there are some behavioral symptoms to BPD. And there are also symptoms that really speak to impairment in processing of self and other. In Section 2, the criteria are the same for adult and youth, but the criteria have to be met for only 1 year to get a diagnosis. DSM-5, Section 2 gives a caution to diagnosing BPD that it must be diagnosed only in those relative unusual instances in which the individual's particular maladaptive personality traits appear to be pervasive, persistent, and unlikely to be limited to a particular developmental stage or another mental disorder. Some of us don't agree with that caution, and I think some of the data that I will be presenting today may be challenging some of that caution. In Section 3, no caution is given for diagnosing PD in adolescents, but they do have a developmental note, which is relatively stable across time, with onsets that can be traced back to at least adolescence or early adulthood. Section 3 divides PD into 2 criteria for all PDs. Criterion A really captures the impairment in self-other processing, severity of problems in identity, self-direction, empathy, and intimacy. And we measure that with the levels of personality functioning scale, which is included in Section 3 of the DSM. There's also PD researchers who are now developing self-report measures for this purpose. And criterion B is the presence of 4 or more of 7 pathological personality traits: emotional lability, anxiousness, separation, insecurity, depressivity, impulsivity, risk-taking, hostility, of which at least 1 must be impulsivity, risk-taking, or hostility. And this can be assessed by the PID-5. A self-report measure, and the clinician can use this, but also the subject can, or the patient can fill this out themselves. So clearly, the PD diagnosis is allowed by the psychiatric nomenclature. It's included, yet there are challenges to assessing adolescent PD, which has made clinicians and researchers reluctant to use it. Firstly, there's a general reliance on self-report and interview-based measure, which are both vulnerable to social desirability for these kinds of disorders, which people don't typically easily sign up for. In adolescence, the problem of abstract criteria is noted. Things like identity disturbance and lack of empathy have made clinicians feel that they can't really ask adolescents about it, because adolescents wouldn't be able to validly reflect on that. And some of the qualitative work that I will present a little bit later will help you see that that's not a problem in adolescents who meet criteria for BPD. Talking about PD and personality requires insight, especially a problem for BPD and a problem for adolescents who are perhaps at a lower level of insight in their developmental course. This has been called the introspection limitation, rely on information that is consciously accessible, which may be a problem for a BPD, which is an ego-syntonic disorder. It's been described as a disorder with a lack of insight, mind blindness, characterized by projection, and a disorder in which we externalize interpersonal conflict, so that people are not able to talk about about their conflict with other people that will help you make the diagnosis. The other problem is self-identified traits constitute only one level of personality functioning and may disregard complex interactions between genetic, epigenetic, environmental, and trait dimensions over time. So these are all the challenges that are faced by assessing PD in adolescents and in general. And so what we really need to do, like in all of psychology and psychiatry, is make sure that our measures are valid. We must use multiple informants, and we must go beneath the skin, which is really what RDoC is asking us to do. For this talk, I'm going to focus just on those two first points there about validity of measures and using multiple informants. So in this table, it goes on to the next page, are all of the measures that have been developed and validated for BPD in adolescents. So this is the child interview for BPD, the PAI BOR by Les Maury, Nikki Crick from Minnesota, who developed the Borderline Personality Features Scale. We developed a parent version and a short version of that. Mary Zanarini's MSI is a screening tool for BPD that's been validated for adolescents, the BBQ, as well as another one from Minnesota BPD scale, Marina Bonavalova, who developed that. The DIPSY comes from Europe, also a trait-based measure. The MMPI has an adolescent version that's been validated for adolescents, and then there's an adolescent version of the PID-5 also available. I'm going to concentrate on the work we've been doing on the CI-BPD. This is Mary Zanarini's measure, developed for children and adolescents, as well as the BPFS-P. And any papers that I can send, please don't hesitate to write me afterwards. I'm very glad to send papers, not only of my work, but also other people's work that I review. So here's the CI-BPD, and this is just the first item. It's a semi-structured interview that asks the teen to reflect on the last 2 years of their life. So actually adhering to the adult criteria in that sense. And it has a whole bunch of STEM questions that helps you get at this criterion of BPD in different ways. And for all of these criteria, or for all of these questions, you really need to get two things, and that's frequency and intensity. It's really the frequency and the intensity that's going to warrant the borderline diagnosis. So lots of teenagers feeling angry, lots of them having trouble controlling their anger, but only a few of them will do this several days a week and will escalate to the point where parents become concerned for their own safety and so forth. So it's frequency and intensity that we look for in the CI-BPD. Mary Zanarini trains people directly to use the measure. And of course, we calculate inter-rate reliability when we use it in our studies. This was data from results of a study that we did with 6,000 teenagers in England. About half girls, they were 11 years of age, so early adolescents, and we did item response theory analysis. So we were interested in seeing how well each of the items or criterion, each of the 9 criteria functioned in terms of its discrimination and difficulty. So these are IRT concepts that helps us tell us how effective each criterion is at measuring the underlying trait of BPD. This graph just shows you the BPD liability and at which point of BPD liability the CI-BPD functions best, where all the information is captured. And you can see it's at the higher end of the BPD liability continuum where the CI-BPD does its best work. You can also see that for boys and girls, it actually functions equally well, which was important given concerns about how BPD manifests itself differently in boys and girls. In terms of discrimination, each of the BPD criteria showed adequate discrimination for boys and girls. The criteria were most discriminating at the high end, as we saw in the graph that I just showed you, at the liability with measurement precision at +1, +2, 2, +3 above on the underlying latent trait. And these were consistent with results from general population sample of adults. So what we see there is BPD criteria functioning very similarly in a young adolescent population as in an adult population. In terms of threshold, abandonment fears and suicidal behaviors were the most difficult symptoms to endorse. And that is consistent with studies that show that these are more rare in adolescents compared to some of the other more behavioral criteria like affective instability, impulsivity, anger in adolescents. So we took this work further, and this time bringing it into the clinical population and 190 patients, inpatients, mean age about 15, 60% of them female. 91% Caucasian, unfortunately not a very diverse sample, and a third of the teens in the sample met criteria for BPD, which is typically what we find in inpatient samples. And we just did a bunch of psychometrics here that I'll go through very quickly to just try and convince you that the CIBPD is a valid and reliable tool to use. So the CI showed support for a one-factor model. That's what we do want to see in a diagnosis. According to classic criteria of validity of psychiatric diagnosis, we want the items or the criteria of the diagnosis to hang together and all load up with decent factor loadings to the underlying trait. You can see that. The Cronbach's alpha is 80. The inter-rate reliability on 15% was 89. In terms of overlap with clinical diagnosis, the kappa was 34, which is on the low side. It's clinically significant, but it's on the low side. And it is because in the setting, PD diagnosis is not often made. When it was made, it was, there was a good overlap between clinician diagnosis and the CIBPD. And then here we just looked at how it correlated with the PAI self-report measure, and you can see the CAI classification, CIBPD classification distinguished well between high and low scorers on the PAI. We also looked here at correlations with YSR. If you're familiar with the Achenbach scales, the YSR and the CBCL, and it correlated as it should in terms of total score with general psychopathology, with the DIRS, the difficulties in emotion regulation scale, again the PAI bore, and Kim Gratz's self-harm measure. And then finally, we also looked at it just with categorical Axis 1 diagnosis. So this is the child diagnostic interview schedule for children, and it does what it's supposed to do again in terms of external validity. I'm going to change tracks now to the BPFSC that was developed by Nikki Crick, published for the first time in 2005. It's a 24-item measure. You just see there the first 5 items. It's rated on a Likert scale. And one of the first things we did was in a sample of 171 community kids, and they were actually boys. They were fairly diverse, as you can see here, primarily middle class. And we just wanted to see how this self-report measure of BPD correlated with CBCL and YSR. And you can see that decent correlations across the board, and which doesn't tell us that much. It just says that psychopathology correlates with psychopathology. What we did here was develop a parent version, and we see a 24 correlation between the parent and the child version, which is consistent with what we always find about a 0.30 parent-child correlation for psychopathology, which is interesting what that discrepancy mean. I won't talk about that today. We also looked here at high scorers and low scorers and whether that increased the relative risk for all of these different outcomes, Axis 1 outcomes, and the BPFSC was found to, especially for conduct, as you can see, increase a risk for poor outcome in terms of conduct problems. This is the same thing, this time for the YSR. I did CBCL in the previous graph. So the conclusions for the BPFSC: modest but significant agreement between parents and children. Teens themselves report higher means for BPD compared to parents. And the cross-method analysis shows strong relationships with externalizing behavior problems, and this is probably because this was a sample of boys. In the next study, we then took the BPFSC back into a clinical sample. This was a very small clinical sample. It's the beginning of our study at the Menninger Clinic, where we compared 31 no BPD psychiatric controls to borderline kids, about 20. And you can see their BPFS scores are significantly different. And we just did a very simple ROC curve analysis to see whether the measure had good sensitivity and specificity, and we used that to identify a cutoff point that we've replicated since then of 66 on the 24 item of BPFSC. We then, that's just our cutoff point there, for optimal sensitivity and specificity. And we then went back into a large sample of community-based adolescents, and then we wanted to shorten the 24 items. So in our previous work on the BPFSC, we noticed that there were some psychometric problems in the measure, and we wanted to use IRT, item response theory, to see if we could streamline and make the measure more effective. And so this is a very busy slide. All I want you to focus on out of the 24 items, these were the items that had decent slope. We usually look at above 1. These were items that had poorer slopes, so we already were able to delete about these 5 items. We then looked at items that showed local dependence. That means that the items correlate more highly with each other than with the underlying latent trait. And that's usually a sign that those items are redundant and can also be removed from the measure. And so we ended up with an 11-item measure of BPFSC that captures BPD reliably, as evidenced by this test characteristic curve that gives you good spread over the latent trait of borderline personality disorder, in addition to good sensitivity and specificity against the CI-BPD, clinician-rated BPD in our adolescents. All right, so in terms of that first myth, the psychiatric nomenclature does not allow the diagnosis of BPD. We clearly say that the nomenclature does allow for it, and there are assessment tools. I didn't have time to go into all of the other assessment tools, but just kind of scratch the surface with the empirical basis for the assessment tools available for BPD in adolescents. In terms of our second myth, these characteristics are normative and not particularly symptomatic of personality disorder. Nearly half of clinicians believe that adolescence is a stormy developmental period and that BPD in adolescence is transient. And when we do look at rates of all of the features of BPD, teenagers engage in a lot of binge drinking, shoplifting, non-suicidal self-injury, and affective instability is a hallmark feature of adolescence. However, if we look at this data, this comes from the CDC, it tends to be the same kids who do all of these things, which means that there's about 80% of kids that don't have these persistent problems. And a subset of this group may be struggling with emerging borderline personality disorder. So this is reflected in community-based studies where the prevalence of BPD has been shown to be 3% in the UK, 1% in the US, and 2% in China, with a cumulative prevalence suggested to be 3%, which again mirrors the prevalence rate of adult BPD. In clinical samples, like in adult samples, it's much higher, 11% in outpatients, 33% in inpatients, and 43 to 49% in other inpatient samples. It's Ken Levy's study. And so here what we did was, this is currently under review, what we did was we transcribed the CI-BPD answers in healthy kids, kids with psychiatric problems who do not meet criteria for BPD, and kids who meet criteria for BPD. And all I have time for is presenting the data on the kids that meet criteria for BPD. And again, if the paper gets accepted, you'll be able to see how it compares with healthy controls and with psychiatric controls. But here's some of how BPD kids describe anger. Sometimes I've hit her, it's the mom, but I scream a lot. I go to my room and just get really scratching myself with anger. I do a lot of stupid stuff when I'm angry. I'm real impulsive. It was in Miami 2 months ago. What happened? She was trying to wake me for school. I was kind of sad. I didn't want to go to school, so she went to wake me up. I pushed her and she fell on her butt. Affective instability. So this is a regular, if we think about how Marsha Linehan talks about BPD, it's a disproportionate emotional reaction to a fairly benign everyday event in the school life of a teenager. 17-year-old describes affective instability. I just get really extreme in different situations. I get really, really happy, and then I'll just flick a switch, and I'll be really, really depressed. Another 17-year-old, I get excited to do something, go out with my friends, and then when my mom tells me no, it will trigger me, and I'll be upset for the rest of the night. Sometimes I get over it, but the original feeling that caused the feeling is still there. So I still have the capacity to go back to that mood. Suicidal behaviors. In 5th grade, I cut myself. 6th grade, I cut myself. 7th grade, I haven't cut myself, but I did once, and that's right there. And she points to her arm. See that scar right there? That was once. That was 2 weeks ago. Not last week, but the week before. Every time I cut myself, I usually cut about 10 times like this. She shows her arm again would fill up, like right here, filled up last year. And she goes on again, talking about self-harm in the way that borderline patients often talk about self-harm in showing and being preoccupied with the self-harm while they're talking about it. Emptiness, which we think, or we often thought that adolescents can't describe, this 17-year-old says it feels like it should make me sad, and I don't cry about them. I just think about them over and over again and analyze them, break them down into the tiniest possible pieces, and then I feel empty because I never actually absorb any of the emotion. I just analyze it and it makes me feel pretty empty. Things that used to bother me, enough to make me cry anymore. So I don't feel like I have any emotional responses to things besides over-analyzing them. Like even when I'm happy, I don't feel like I'm ever in the moment. And I'm never really feeling things for what they really are. Like when people are laughing, I'm laughing too, but I never feel like I'm enjoying myself. Or in my heart, it literally feels like there's an empty hole in it when somebody's just like really unfair. Somebody's feeling a feeling, or is really happy, or really upset, or just feeling a feeling, and I try to feel it in something, and I can't. Why can't I feel that feeling? So very similar to what adult borderline patients would describe. Identity disturbance, I feel like a little bit. I have no identity sometimes. I feel like often when I first meet people, I only act like a chunk of who I am. Like I don't know how to, and because it becomes really confusing enough to really know which me is really me. Why is it confusing? Because I feel sometimes like a blank canvas a little bit, but sometimes I feel like a lot of times I find myself doing our actions with words, making so that not maybe what would be the best for me, but more like what would be the most dramatic. Impulsivity, they understand impulsivity very well. We did expect that they would be able to talk about drinking and smoking and illicit sex and so forth. So no problem understanding impulsivity criteria. Abandonment fears, I've always been worried about losing people. Have you lost people? Yes, emotionally. Who have you lost? A lot of friends, also family. What do you do when they want to leave you? I get really shaky and just keep thinking about it and worrying about it and start like crying. I just imagining the worst. I try to keep it to myself because I feel like if I reach out to them, I'm just going to push them away. But you know when you're like, when there's like something over there and you reach for it and you can barely touch it with your fingertips, but you can't grab it and you just push it a little bit more and more. I feel like it's like that. Has it happened to you? No. But I've seen it happen to other people. I don't want it to happen to me. I don't want to be like the controlling one that makes them stay. If they don't want to, I self-harm when feeling abandoned. At the same time, sometimes I push them away before they get the chance to push me away. I go off on them, or sometimes to push them away before they get the chance to do it themselves. Unstable relationships, it happens over a really small incident, and it goes from loving them to completely calling them my enemy. Yes, I'm not really good with relationships, that's why I don't really have any close friends. Paranoid ideation, my mom says I don't have evidence, but I don't feel like it's so crystal clear that it's there. And my therapist told me over and over again not to make judgment, but I always feel like people are talking about me, but there's no real evidence. A lot of time I feel like other people are out to get me. Sometimes my opinions of people can't change, and people try to be nice to me, but I think they're malicious. Dissociation, the teen goes ahead and describes a good description of dissociation. It's a mechanism of coping. It's a feeling, not really moving her muscles, and it has this really strange but really good feeling throughout my whole body. I don't usually like to talk that much, really only move my eyes and sometimes my head when I do it, and it kind of just a numbing effect, but it's also really good feeling. I don't really feel any crazy emotions that I usually feel when I'm doing that. So in terms of the features, we see a very stark difference in how teenagers with BPD talk about these symptoms compared to healthy controls and even psychiatric kids who have a lot of these same features. They are more intense, more frequent, and they are more preoccupied with them. So literally the transcriptions of the borderline teens talking about these symptoms were 3 times the length of the psychiatric controls and healthy controls. The psychiatric controls and healthy controls sounded fairly similar in how they talked about these symptoms. In terms of better explained by Axis 1 disorders, I'm just going to again give you a glimpse of the research out on this. So the reason people have this notion that Axis 1 can capture BPD and that we don't really need BPD to capture anything extra is because of the high comorbidity rates in adult studies. but also in adolescent studies. We have seen in adolescents in the children community study 50% comorbid axis 1 disorder. In clinical samples, it goes up to 86% having at least one comorbid disorder, half of them MDD, ED 31%, 25.9% disruptive behavior disorders, and then substance use. So when disorders are comorbid like this, we assume that there are underlying traits that account for the covariance between these disorders, that account for the comorbidity between these disorders. And so it's led several people in the field to do these kind of complex factor and analytic studies into the metastructure of psychopathology. This was one of the first that actually tried to model BPD in this metastructure of psychopathology of common disorders. And we know that typically in these factor analytic studies, internalizing and externalizing come out as two factors. Internalizing often factors out into fear and anxiety. And then what Borderline did was to load both on internalizing and externalizing, suggesting that it could be a kind of compound of both of these disorders, but with enough unexplained variance to suggest that it's still its own disorder. This was also shown in one of Bob Kruger's studies with one of his students. And here again, you see for both males and females, BPD crystallizing out as its own disorder, but loading both on internalizing and externalizing simultaneously. So capturing both of those broad features of psychopathology. What we did was to try and see if we can replicate this in adolescents, and indeed we did, almost exactly the same, except that internalizing didn't actually function the same way as in adults. We couldn't really distill fear and general anxiety in the way that internalizing usually fear and distress in the way it usually comes out. Interestingly, in this study, what we also did was to measure, we used child attachment interviews. This is about 500 inpatients. Child attachment interviews to validate the borderline factor as separate from the internalizing and externalizing factor, and it did indeed show differential correlations with the CAI in the sample. So again, looking back at that myth, we do see BPD crystallizing out as its own disorder, and there are lots of models to try and talk about where BPD or personality disorder in general fits in our thinking generally with psychopathology. Looking at the fourth one, adolescent personalities are still developing. I think everybody in the room who has a baby knows, or have had a baby, knows that little ones come into the world with discernible little personalities called temperament, and that the research has shown that this temperament is fairly stable. So we know from the developmental literature that this idea that kids don't have personalities is not supported. Moreover, if we look at the course of BPD, we know that it follows this typical course. It has its onset in early adolescence, it kind of goes up in middle adolescence a little bit, peaks in late adolescence and young adulthood, and starts to go down in severity in mid-adulthood and late adulthood. And studies that have followed up samples with in-person stability have shown rank order stability for PD symptoms. And that's really just what it means, is that a person retains their position in the rank order of where they lie on the BPD continuum over time. So it may be that the mean changes, but people's rank order does not change. All right, so moving on to the last challenge or myth for BPD. I'm just going to very briefly, this is work that we have just analyzed, so it's not really ready for publication at all, and we'll probably take a stab at some latent growth modeling instead of what I'll be presenting to you today. But we looked at 66 inpatient adolescents meeting criteria for BPD compared to 106 psychiatric controls. And we tracked them admission, discharge, inpatient treatment, 6 months, 12 months, and 18 months. And what you can see here is that the borderline kids obviously start higher in terms of borderline symptoms than the non-BPD psychiatric controls, but they have exactly the same drop. There was no interaction in terms of group and time, with a main effect for both groups for time. And you can see that they drop around 6 months after discharge below the clinical cutoff for BPD. So these kids do get better. This is self-reported borderline symptoms. They also get better in terms of parent-reported borderline symptoms. So here they're already at discharge below clinical cutoff, very steep curve going down, and they are catching up with their non-borderline peers. So the message is a similar message that adult studies have shown, Mary Zanarini's longitudinal work, that people with BPD do get better. I think that idea of this treatment-resistant disorder is being debunked, and also for adolescents. We did, however, identify a group, 23% of them on the self-report, that were persistent, that never dropped below the clinical cutoff, 11% on the parent report, and they do show interesting differences. So here we literally just took the DIRS, the subscales of the DIRS, and we looked at whether these kids, these are baseline DIRS scores, whether the DIRS determined whether someone was in the persistent or non-persistent group. Sorry about those asterisks. So indeed, that significantly, so emotion dysregulation at baseline, at admission, is a good finding for DBT. The emotion dysregulation at baseline can predict to some extent who remains in a persistent group. So if there's high emotion dysregulation, a kid may stay in the persistent group. Same for hypermentalizing. I don't have time today to talk to you about mentalizing and hypermentalizing, but hypermentalizing is the only mentalizing category that puts a person in this persistent group. So these are malleable treatment targets that we absolutely have to identify, assess for early on in treatment so that we can address them better and try and get kids out of that persistent group. These persistent kids also have poorer outcomes of 18 months. At 18 months follow-up, this is clinical cutoff on internalizing and externalizing and total score, and you can see they don't really ever drop below clinical cutoff. So they're a group that we really need to watch. Are there treatments that work? Yes, there are. So we see these kids get better over time. This was just kind of following them up, but there are also kids there are also RCTs for cognitive analytic therapy, CBT, DBT, as well as MBT, and more detail about this can be found in a JCPP paper Pete Fonagy and I published last year. So there are treatments that work for kids with BPD. We're just not typically using them. All right, so back to our 5 myths. Psychiatric nomenclature does allow for the diagnosis. We can reliably and validly assess BPD. Adolescents with BPD do understand the criteria when you ask them about it. Experiences of BPD adolescents are qualitatively different from non-BPD psychiatric controls and healthy controls. BPD can be distinguished from internalizing and externalizing disorders. It shows rank order stability over time. And there are a group of teens who show a persistent BPD pattern, but treatment is available, and it appears to work based on the RCTs that we currently have. So is it not more stigmatizing to pretend that an adolescent does not have the disorder or to avoid the appropriate treatment because the diagnosis is made? I struggled myself with this for a long, long time, and it was really Andrew Channon who got me around to, saying there's nothing wrong with saying to a family, your child meets criteria for BPD, and how we do it in my clinic over at UH at the moment is we say to the parent, your child currently meets criteria for BPD. She has above 5 criteria out of the 9 criteria for BPD. It's also shown in the self-report measures that we've done. However, this is the right time to come to the clinic and get treatment because things are malleable still. So that's how we tend to talk about that. The idea that BPD is this chronic disorder, and I remember for a while there when I submitted papers and I started my paper with BPD is a chronic and severe disorder, I would get the reviewers writing back and say, don't call it a chronic disorder because we know BPD, like depression and anxiety, comes and goes. There is malleability there, and I think it's our job as clinicians to move beyond this idea that this is not a treatable disorder. So we did, a group of us in May 2014 at the APA meeting in New York got together. It was really Perry Hoffman that got us together from the NEA BPD. And we organized this very loosely informal group of people called the Global Alliance for Prevention and Early Intervention. And we have all of these goals that I want to make you aware of: promote early detection and timely intervention for BPD, match treatments to individual development and to phase and stage of the disorder, work with families at all stages of intervention, improve access to evidence-based treatment, increase the variety of availability of treatments across all levels of the health system, to develop the mental health workforce by updating knowledge, culture, and practice in relation to borderline personality disorder, to address problems of stigma surrounding BPD from the individual and the family standpoint, so that it's not a disorder that we cannot name, and to integrate service advocacy in the above aims. So we've had a lot of work that we've done since 2014. We got our European colleagues, Australian colleagues, South American colleagues involved. We basically just have a telephone conference once a year and then see each other face-to-face during ISSPD, ESSPD, or NASPD. But we do one position paper a year. We've just submitted our first position paper with someone else from the group taking the lead every time. We've instituted a special series in a journal, open access journal, in which the fees are waived, by the way. So if you do work on adolescent BPD, it's a good journal to submit to. I'm the associate editor, and our impact factors will be coming out soon. So it's a special series just focused on adolescent and child PD in general. It doesn't have to be emotion dysregulation, but it's just in general. So it's trying to find a home for some of this work. We do committee work on assessment, intervention, and training. We arrange local conferences. We're developing a resource library, and we're trying to get a multi-site study off the ground. So anybody interested more in the GAP work that we're doing, please contact me and I'll provide you with information. It's very open. Anybody can be a member if you work with BPD kids or you do research with BPD, you're a member and you become part of the group. We loosely define just to kind of be a voice for this agenda until it's addressed. Then we'll disband. So I want to thank all of you, the Menninger treatment team and research team, the treatment team at the Harris County Psychiatric Center, who I work closely for collecting our other data, students of the Developmental Psychopathology Lab, and all of you for listening. Thanks so much.
Thank you, Carla. Obviously, I was very excited to have you here, and so some of this hopefully isn't new to people in the room. We don't have anybody pushing up against us, so I realize some people might have to leave, but we actually have time for questions.
Thank you so much. Given what you're sharing about the longitudinal course of the disorder, especially its treatability, do you have a personal opinion on the name of the disorder and whether that's something we should be looking at renaming?
Yeah, a lot of people out there have suggested emotion regulation disorder or something like that. You know, I've gone around the block with this myself, and in the end, I think semantics, you create a new stigma. It's not actually the word that creates the stigma, but all of us creating the stigma. So I don't feel we need to change the word. What I do think may happen in time, where the data is going, is that I don't think we will have separate personality disorders anymore. So I think we may get to a point where we just talk about personality disorder. Do we need to talk about disorder? I don't know. We could talk about, personality impairment or maladaptive personality. But I think what might happen is actually all the names may be ditched in time. They don't seem to. The factor analytic work does not support 10 discrete disorders. All of the essential features of PD in general seems to be captured by the BPD diagnosis in factor analytic studies. So that's what I think may happen. And for the time being, I think it's okay to continue on. But that's my personal opinion, and lots of other people feel we should call it emotion dysregulation disorder. Yes.
So as a follow-up to that, do you think DBT would be a good way to treat all personality disorders, as it has been shown to be effective for?
I do think so. I think DBT is a good way. I do think DBT has its limitations as well. And so I think DBT is very skill-based. And like all therapy, if you do it well, you move beyond the skills. And if you do DBT well, you move beyond the skills and you get to the relational piece. But I think that it can easily happen. I remember when I started out with CBT, I'm actually a CBT, mostly a CBT person. And, it's very easy to hide behind the skills and the techniques. And we don't get to the relational piece, which is kind of the kiss of death for PD, because a person will get better in the short term for sure, but they will not what Kernberg used to talk about as the personality organization. We won't shift the personality organization. So that's really where you need to get to the more relational piece, which comes from the more psychodynamic traditions. So I think we're at a place where we can have multiple approaches. I think we passed branded therapies. And as we are seeking for common factors that cut across all disorders, we are seeking for common factors that cut across all psychotherapeutic and totally focusing on emotion dysregulation is a very important puzzle of that. But I think we can probably go a bit broader than that. But treating all PDs, I don't think it matters that we have a BPD specific treatment at all. I think we absolutely should look at the common factors across all PDs in psychopathology and treat that. I think that's where we're going to move the needle. Yes.
Well, another related question. So is it your belief that eventually, how should I say it, one might be thinking about precision medicine for the personality disorders? Treatments that are being tailored to individual constellations of
Absolutely.
affective, neurocognitive, self-regulatory, etc.
Absolutely. I think that's where the field is moving towards. We're far from doing that, but I think trying to have a profile that goes beyond the borders of the DSM categories is where we're moving towards, so that we can say this person has a profile of, high emotion dysregulation, low agreeableness, etc., and that we can treat those dimensions rather than actually being confined by a manual that's designed specifically for one particular disorder, as defined by the DSM, which we know has its troubles. Yes.
I had a question about more with relationships. I'm from outpatient mental health adult day treatment.
Can you put up your hand, because I can't see where you are? Ah, there you are. Thanks.
We have had people that have had years of DBT and then they're sent to us because they just can't apply skills, or it's not working. And so we use about 100 different techniques, including those with DBT and CBT. And do some brush up skills, and then there is a lot of relationships in the outpatient mental health. And so I just wondered if you could say more about the relationship piece, because we have had some people sent to us from DBT that were too much trouble for the DBT people.
This is a population that the disorder comes, like all disorders, it comes back, and it's you really commit to a lifelong management of the disorder. The problem with the personality disorders is they come back in a dramatic way that really derails the person in many different ways, and they almost feel like they start from scratch. We also, in our clinic, get people back from DBT, and we have a fantastic DBT center in Houston. So the relational piece, I'm coming from the mentalization-based framework, which is psychodynamically informed. Even though I was trained first in CBT, it was really when I moved to the US from England, I was trained in the Oxford School of CBT, which does really good CBT. And but came to the Menninger Clinic, started working with Peter Fonagy, and got introduced to MBT. With my background in social cognition, it made sense to me to go there as a kind of translational endpoint of my developmental psychopathology work. And so the idea is really that you are developing a stance, an approach to thinking about yourself and other people in the context of relationships, which changes your personality functioning. So we're really addressing criterion A. So if you think about DBT, in many ways, DBT I'd be interested in what you guys think, who's really doing DBT day in and day out, Mike, but DBT in many ways addresses criterion B of personality disorder. So you've got all of these, traits of impulsivity and affective instability and so forth. But at the moment, DBT does not address, and I think MBT does not address the traits very well. So, I mean, that's why the two need to work together. But so the relational piece is really teaching the patient a particular stance to interpersonal relationships and the self that changes the way their personality functions. I said this morning to folks in the eating disorder group that a lot of patients, when they've gone through MBT, still has to do it very deliberately. They would say to themselves, I'm not mentalizing right now. I know I'm not mentalizing because I'm feeling really actively. But if I were mentalizing, I would be thinking that there might be a different perspective on this right now. And I would be trying to find out what that perspective might be before I act. Now, I said to the guys this morning as well, how to teach people to mentalize is difficult. And I'm working currently on a manual to try and demystify that and make it easier for people, almost in a skills-based, CBT-based way, to learn how to mentalize. Because the way that the mentalization-based treatment manuals are written right now, it makes it hard to access at the moment, and Peter Fonagy and Anthony Bateman are the first to say so. So the whole mentalization group is working on making it a little bit more accessible, but you have to get to that relational piece in the therapy where the patient and the therapist can sit down and talk about what happens between the patient and the therapist at that time, not in the way that psychodynamic therapy is typically done, or psychoanalytic therapy is typically done that, because we know that that's iatrogenic, but using the skills that mentalization-based therapy offers. And so there are training in MBT in the US, and it's usually at McLean and in UCLA. But it hasn't hit the mainstream in the US as it has in Europe. But anybody who has questions about that can contact me, and I'm happy to put you in touch with people that can train MBT. But I would say there's this caveat: I have students that have gone through the training several times and still struggle to do it. And so in MBT, we really need to make it more accessible for people to learn how to do it. Otherwise, the treatment won't be disseminated and won't reach its promise.
I think we'll probably stop there. As a DBT therapist, I would say I think we do that piece. I think what's missing a lot in DBT programs is having a therapist who is trained intensively in DBT and is focused on doing DBT in every session, because we will talk about it as emotional exposure. We will talk a lot about doing in-session treatments and identifying in-treatment behaviors, which I think is the mentalization piece that you're talking about. So I think that some of the people who are getting missed, even in DBT, sometimes it's just a therapeutic relationship, because I don't think that every DBT therapist is going to be the right fit for every patient. That's a piece of it.
Peter Fonagy and Anthony Bateman would always say any good therapy uses a mentalizing stance. If your patients are getting better, you are mentalizing, and you are teaching them to mentalize. I think all that MBT does is putting it front and center and really making that the first focus is the treatment. But there's a lot of stuff we don't do very well.
Thank you, Carla.
Thank you. Thank you so much.
I'd like to remind all of the students in the room, including the doctoral folks, postdocs, even if you're a practicum student, there is a lunch with Carla at 12:30. Hopefully they will not still be drilling on the floor when we get up there. I asked them to stop, so please join us.